Whenever we have adequate surfactant, whenever we're using adequate PEEP above closing lung volume, pressure, you have a deflation stability whereby during inspiration there is adequate alveolar expansion, and during expiration there is deflation, but not atelectasis. However, when there is deflation instability, you may have inflation during inspiration, but with residual atelectasis, and definitely in expiration you'll have more atelectasis. And that results in atelectotrauma and or recruitment, derecruitment, lung injury. In an open lung alveolar recruitment, we aim to attain or achieve deflation stability, keeping the air sacs open during expiration. So again, the mechanisms of lung injury, one is volumetrauma, when we overstretch the lung to its total lung capacity. And on the pressure volume curve, the volume pressure curve, you can see this peaking here. Because as you can see here, even at lower pressures, there's no change in volume because the lung is already overstretched. And the second mechanism of injury is here, where there is atelectotrauma and recruitment, derecruitment injury, whenever your PEEP is below this critical closing pressure of the lung, because here you are already in atelectasis. So you can have stable ventilated lung with open inspiratory, expiratory alveoli. This is ventilated during inspiration, but you have recruitment, derecruitment injury here, and here you have atelectotrauma. So optimally, we would like to ventilate babies with appropriate tidal volume that is above the critical closing pressure of the lung with adequate PEEP. You can still ventilate with normal tidal volume, but if you use low PEEP, you can have atelectotrauma and recruitment, derecruitment injury. You can still ventilate with normal tidal volume, but have overdistension and volumetrauma if your PEEP is too high, and you can have both if you're using high tidal volume and low PEEP. The idea here is with using volume target ventilation, we can control for the tidal volume, but that does not necessarily mean that we can eliminate atelectotrauma, recruitment, derecruitment injury, so we have to combine volume target ventilation with an open lung strategy. So the benefits of volume target ventilation cannot be realized without ensuring that the tidal volume is evenly distributed throughout an open lung. So two things. One, using a volume guarantee ventilation to prevent volumetrauma, but use an open lung with PEEP just above critical lung closing pressure to prevent atelectotrauma, recruitment, derecruitment injury. The open lung have been demonstrated to decrease inflammatory processes, whether you use high frequency or post-pressure ventilation compared to control. And also if you use zero PEEP, you can have more inflammatory mediators because you are having non-open lung. Now, the limitations of traditional volume ventilation is the flow sensing. It used to be in the returning loop of the ventilator away from the baby. Now we're using flow sensors at the Y piece. We can measure inspiratory and expiratory tidal volume that allow us to determine the leak in the lung and compensate for the leak. With ETT leak, some inflation tidal volume does not enter the lungs during inspiration. So we watch for expired tidal volume rather than just inspired tidal volume. Approximately 46 ml per kilogram of tidal volume. Don't forget that babies may contribute a lot to tidal volume when they are spontaneously breathing. So different ventilators, different approach, but the recommendation is to really monitor both inspiratory and expiratory tidal volume at the Y piece of the ventilator. That's your best ventilator. To avoid tidal volume damage, the ventilator must adapt rapidly to changing respiratory parameters. So if baby is breathing in synchrony or out of synchrony with the inflations, so the ventilator has to adjust for that and give the appropriate tidal volume. Baby is crying, baby is splinting, apnea, compliance, and resistance changes. So if the compliance improves, then instead of the ventilator has to respond to increase in tidal volume and adjust the pressure to maintain appropriate tidal volume, as well as a good estimation of the ETT leak. So here, we try to maintain tidal volume by pressure changing and adapting to such kind of variable changes in the baby. In volume control ventilation, if, for example, the compliance improve, you can see that the volume maintained, but the pressure was dropped. So from here to here now, but maintain the tidal volume, so that will avoid volumetrauma. Whereas in pressure control ventilation, when the compliance improve, the pressure stays the same, but the volume increase, and that can cause not only volumetrauma, but also hypocapnia and the sequelae of hypocapnia. Again, here you can see the volume is less than the limit, so the pressure goes up, and then here the volume is low, the pressure has to go up to compensate for decrease in volume. Same as here. The presumed benefits of volume target ventilation is maintenance of relatively constant tidal volumes, prevention of overdistension and volumetrauma due to surfactant administration. So you give surfactant, there's improvement in compliance. Now you have more tidal volume, but if it's controlled, then you can keep it stable. Lung volume recruitment, clearance of lung fluid, automatic lowering of pressure support level during weaning, so you don't have to keep after the ventilator, it's an automatic wean, compensation for variable respiratory drive, and so on. It's been demonstrated that with using volume guarantee with assist control compared to assist control alone, you can have values outside the range less with volume guarantee. And PCO2 less than 35 was also less when you use volume guarantee than assist control alone. There are two prospective randomized trials that looked at volume guarantee markers of lung inflammation with assist control, and they looked at the bronchoalveolar lavage, used volume of 5 ml per kilogram. It showed that it reduced pro-inflammatory cytokines levels and decreased duration of ventilation. In summary, when compared to PLV, volume guarantee results in same or lower PIP, more stable tidal volume, less hypocapnia, faster recovery from forced exhalation episodes, works better with assist control than SIMV, faster recovery from suctioning, pro-inflammatory cytokines decreased, and faster weaning from mechanical ventilation, and higher tidal volume needed with advanced postnatal age. This is the Cochrane meta-analysis, 2017, for volume target ventilation versus pressure control ventilation. And it shows that BBD is reduced by about 25%, and grade 3 to 4 IVH, PVL, severe IVH, pneumothorax, hypocapnia, all were reduced by about 50%. And the days on mechanical ventilation were also reduced. What tidal volume should be set? The anatomical dead space is about 2 to 2.5 ml per kilogram. The expiratory tidal volume about twice. This gives adequate ventilation usually. So we're talking about 4 to 6 ml per kilogram is appropriate for infants with respiratory distress syndrome. This allows, because the FRC in those babies is about 11 ml per kilogram, and the total lung capacity about 19 ml per kilogram, 19 minus 11, that's 8. So anything above 8 or above ml per kilogram may cause volumetrauma, because 8 above the FRC will reach you to the total lung capacity. This study have demonstrated that tidal volume may be higher in tiny babies, like 400, 500 grams, up to 6 ml per kilogram, compared to 800 grammers, which maybe 4 to 5 ml per kilogram is sufficient. Also, babies who are older tend to require larger tidal volume in the 6 ml per kilogram rather than in the 5. Babies with meconium aspiration syndrome also require around 6 ml per kilogram of tidal volume higher. When you set access control volume guarantee, you set the backup rate. The lower the backup rate, the more triggering with the patients. So here they use 30 as the lowest, but you can even go to 20 if you're not concerned about apnea. Clinical guidelines start immediately upon initiation of ventilation, which is the current now. Most people like to start with assist control volume guarantee ventilation. Set the tidal volume at 4 to 5 ml per kilogram during the acute phase of RDS, but use larger tidal volume in tiny infants, infants with meconium aspiration, and older infants. It works better with assist control or pressure support than SIMV. Set PIP limit 25% above the PIP currently needed to deliver the target tidal volume, and report both PIP limit and the working pressure to see how the baby is doing. So the baby will maintain same tidal volume, but using lower pressure. That means the baby is improving. Allow self-weaning of PIP and avoid reducing tidal volume. Just, it's a self-wean. Why not to use volume guarantee? When not to use it? When the presence of a tube leak over 40 to 50%. Some ventilators now, I think they get to, they say, 70%. In summary, any apparatus that you use or any mode that you use, it is the success of which is dependent on knowing and having the skills to use it. Thank you.
Thank you, Dr. Ramzi, and I will call the second speakers. He's Professor Paolo Manzonai. Dr. Paolo is graduated MD degree in University of Torino, School of Medicine. He's a consultant in pediatrics and neonatologist in Sant'Anna Hospital, Torino, Italy. Also, he's a research professorship in Duke University of USA, published around 150 research papers. And he's going to talk about the disparity outcome after preterm birth, a long and difficult journey. Mike is yours, Dr. Paolo.
Thank you very much, and it's my pleasure to be here. I want to acknowledge and be grateful to the Neonatal Society of Saudi for this invitation. It's always a pleasure. And my first talk is about the outcomes on a respiratory point of view of preterm birth. Where is it? Here, okay. This is my disclosure. And my main disclosure is this one. I belong to this international expert network on RSV called the ResVNet. It's an independent research network with some 16 experts from different areas of the respiratory world, neonatologists, infectologists, pneumologists, and so on. And this is the outline of this talk. First of all, I will tackle the point of premature neonates being prone to late hyperresponsiveness that lead ultimately to wheezing or asthma. Then I will try to give you insights about the mechanisms producing wheezing or late asthma in formerly preterm infants. And finally, I will tackle the point of interventions that can be envisaged to prevent these detrimental effects of prematurity. First of all, let's keep in mind that preterm birth is a risk factor actually for longer-term airway hyperreactivity. And this is not only attributable to BPD, meaning that BPD may be a part of this problem, but it's not the only driver for these negative outcomes, because the anatomic immaturity plays a major role, and additionally, many risk factors can add to this pattern, to this network of causes. Let's keep in mind that our premature neonates mostly are born during the saccular period of development of the lung. So those being born already in the alveolar period are usually older than 36 weeks of gestational age. And this implies that anatomically, lungs, bronchioli, and alveoli are more immature, both in terms of development and in terms of size. In fact, the size of the alveoli is very much reduced as gestational age weeks go down, down to 1/6 of the normal range in a 30-week gestational age baby. The same applies to the lung volume, the lung weight, and also the number of alveoli. And a measure and a consequence of these anatomical impairments is the following one. When we measure the FEV1 during the school age, we see from meta-analysis that a decrease by 7% is already there in all premature infants, regardless of being a BPD or not. When these babies are also BPD, this decrease increased down to 16%. So we have a portion of detrimental activity of the lung that is already nicely attributable to prematurity itself and not to additional risk factors. And this is another view. A meta-analysis showed that this risk is more than twofold our, is ranging between 1.5 and 2.8, depending on the extent of prematurity. Other ways to demonstrate this point are shown in these next slides. This is a study performed already 20 years ago and showing the airway hyperresponsiveness in school children born very preterm was extremely higher in babies born with prematurity, regardless of being a BPD or not. And when we measure the outcomes in terms of wheezing episodes or asthma episodes, we end up by demonstrating that these babies are more likely to be wheezers, to be asthmatic, to be under medications, and to be affected by recurrent episodes of wheezing or asthma disorders, both in the first 5 years of age and also in the later age, in the so-called school age. So the point is now to understand which mechanisms underlie these disorders, and I will show you some hints about animal models and about some intriguing hypotheses explaining why this phenomenon occurs. Prematurity per se is, of course, the major driver together with oxygen exposure, but also we need to consider early exposure to infections, both in the NICU and outside in the NICU, besides the usual environmental variables such as pollution, smoke exposure, and overcrowding. Ultimately, we have this curve of pulmonary performances in premature infants. Lung immaturity, infection, passive smoking, early atopy, and a number of other variables that I will take later on all of them affect the immature lung, determining that the curve of performance of these lungs will likely be lower and less longer lasting than in term babies without additional risk factor. So if, by example, a normal term baby is destined to become a COPD adult when he's when he will be 65 years old, a premature baby is likely to become a COPD with 10 years in advance. That means that these babies may be likely to become bronchoobstructive already, not in elderly age, but in late adult age. Let's tackle some hypotheses. Imbalance of neural regulation of airway caliber, of course, is there. We know that smooth muscle epithelium balance and vagal balance are impaired in premature infants. But we know also that the response to lung parenchymal injury may be affected, may be overexpressed, ultimately leading to hyperinflammation and recurrent phenomena of cytokine damage. But we have also another intriguing point that is going against the actual trends of managing the babies. Through animal models, we have the suspicion that early exposure to CPAP may elicit longer-term airway hyperreactivity. Therefore, this very nice study, it was published in the New England Journal of Medicine last year, was aiming at comparing two periods of ventilatory strategies in a third level NICU. A first period with limited use of CPAP versus a second period with increased use and routine use of CPAP. In the recent period, there were more infants survived. They were less frequently intubated, but they were undergoing more CPAP days. And the FIEV1 at 8 years of age was significantly lower in the second period compared with the first one. And this is going against our belief, but it's actually true. In the first period, FIEV1 was higher despite the existence of ventilatory techniques that were probably not that modern and not that appropriate compared with now. So which could be the underlining reason for that? We have an animal model, a mouse model of CPAP, and this has been published in the pediatric research, showing that the response to methacholine in the small airways is increased in CPAP pups, rat pups, over the